una capacitación en Point of Care Ultrasound. El concepto es que tienes patologías que tienes que detectar bastante rápido, emergentemente, sea en clínica o sea en la emergencia, y a veces no tienes un radiólogo disponible o no tienes estudios formales, pero vos adquirís las habilidades para detectar si alguien tiene, por ejemplo, líquido libre, si alguien tiene una colecicitis, si alguien tiene una hidronefrosis. Entonces vino un equipo de Estados Unidos, una organización que se llama Hope Imaging. Me puse en contacto con ellos luego de una conferencia en la que anduve en Kentucky en noviembre. Gracias a Dios ellos propusieron la idea de venir por una semana a capacitarnos en esto. Entonces nos dieron acceso a su plataforma. Estuvimos viendo varios de los videos y tutoriales y talleres, y toda esta semana es prácticamente un manejo práctico, entonces evaluaciones en tiempo real. Las cosas importantes que tienen que saber es que no es, o sea, el Point of Care Ultrasound, el punto no es reemplazar a un radiólogo. El punto es poder ver una patología en el momento que te pueda orientar, sumado a todas tus habilidades clínicas, claro, y poder referir al paciente al lugar adecuado, del tratamiento adecuado, el tratamiento inicial, pero siempre pedirle su estudio formal. Ahora, hace un montón de tiempo yo subí una story en mi Instagram haciendo Point of Care Ultrasound de una vesícula biliar, y un montón de gente me empezó a poner que me quedara en mi área de trabajo, que eso le competía a radiología, que yo solo era médico general, que dejara de hacer cosas. Y estoy de acuerdo en el punto de que si yo estuviera cobrando por hacer eso, estaría totalmente mal, porque para eso está el radiólogo. O sea, yo no creo en eso del médico general que es ultrasonografista y que cobra por hacer estudios como radiólogo. Honestamente no estoy de acuerdo. Si no estamos cobrando, o sea, no lo estamos haciendo por el punto de cobrarle al paciente o algo, sino que realmente llega un paciente con abdomen agudo y yo ya pienso que pueda tener una colecistitis, por ejemplo, y reviso y lo confirmo, excelente. Puedo ver el conducto biliar común, puedo ver cómo está el cístico, puedo ver cómo está la vesícula, más o menos cuántas piedras, dónde están las piedras, qué tan inflamado, etcétera, etcétera. Entonces, hay mucho debate todavía en la comunidad internacional sobre qué tipo de personal médico debería hacer ultrasonido en el punto de enfoque. Ya es parte de la currícula médica de los estudiantes de medicina en Estados Unidos. Ya es parte de la currícula del residente de medicina de emergencias, del residente de cuidados intensivos, del residente de anestesiología, del residente de neumología, del residente de obstetricia, de medicina familiar. Entonces todos nosotros podemos aprender ciertas cosas de ultrasonografía básica para ayudar en el bedside, al lado del paciente. Por ejemplo, me llega un paciente con lo que yo claramente sospecho que es una insuficiencia cardíaca congestiva, y puedo revisar su corazón para más o menos estimar una fracción de eyección según diferentes parámetros. Eso me ayuda muchísimo, no tengo que esperar para mandarlo a un cardiólogo para ver qué tan mal está el corazón. Sí lo voy a mandar, obviamente, cuando ya se logra estabilizar, pero así puedo ver. O me llega un paciente que tiene mucho edema en sus miembros inferiores, pero tiene las mucosas secas. Entonces, ¿a quién le creo yo? ¿El paciente tiene sobrecarga de fluidos o realmente está deshidratado por restricción de fluidos? Reviso fácilmente, veo cómo está su vena cava inferior y veo el estado de líquidos de su cuerpo. Entonces tiene muchas utilidades. Podemos ir mejorando y aprendiendo de esto e incorporarlo en nuestra práctica clínica.
and I'm from Illinois, just west of Chicago, and I am a clinical professor in a in-hospital program for formal sonography students, ultrasound students, but we do a lot of collaboration with our residents and ER physicians to teach them point of care ultrasound, and that is what I love to focus on. And we also teach our students it as well in the curriculum. And I have the absolute blessing of being able to travel around when needed to offer some training, mainly to these providers and physicians in the point of care ultrasound.
Thank you. My name is Molly Batten. I am currently the Assistant Program Director for ESP Ultrasound, and I also teach at a local college in St. Paul, Minnesota. I also have an online presence with YouTube tutorials and ultrasound physics videos. So,
can you tell them the name of the channel?
Sure, it's Sono Nerds, SONONERDS.
You're definitely going to find that in the link in the description here below. So you can go and if you want to start learning point of care ultrasound, you can definitely head over there. Which brings me to a question I have for the two of you. And it's in relation to, in Honduras, point of care is still something absolutely new. There's still a lot of backfire from different attendings and consultants, and people don't really understand how useful it could be bedside, on the ER, on primary care. Do you have any insight on that, or how do you prevent people from thinking that when doing point of care you're replacing a formal ultrasound, for example?
Yes. When Pocus first started, that was kind of the fear, especially as formally trained sonographers training. There was a fear of training them out of our jobs. But I do honestly believe that there's such a wide, there's just such a big difference in what we're looking for. So the point of care ultrasound, I want a clinical answer right now. I want it fast. I want to answer to these clinical symptoms. It's replacing the stethoscope. If I can put a camera on it and see inside, why not? And so we haven't. I thought maybe that we would, kind of see there is sometimes some tension, but I thought we would maybe see a drop in formal in referrals to ultrasound, but I really haven't. I think we're getting clinical answers quickly for these patients to know they immediately need surgery, where resources are abundant, where they can get a formal ultrasound or a full workup ultrasound. We're getting quick clinical answers, we're saving time, if surgery is needed, for instance. And then the referrals that we are getting are warranted. They're really, we'll get a quick clinical answer, and then they will always follow up when resources are there. They will always follow up with the formal ultrasound. So we're getting even more in a business aspect. You're getting more, and also warranted exams. Now, Pocus in an underserved, population is absolutely just the creativity. This spot, from where we've traveled, is honestly has the most creative, critical thinking applications for point of care ultrasound that I've never even seen before. And so we would just love to dive into the answers we can get. For instance, following up on the efficiency of medications, and if we can use an ultrasound for that, when maybe in other places in the world we would never even have thought of it. That is the really exciting part of Pocus ultrasound. When you don't have the luxury and privilege of CT, MRI, even consistent ultrasound radiologists, and an X-ray. So that's exciting.
Thank you.
Yeah, absolutely. I feel probably the same way when Pocus first started. I think we were all very nervous that it was going to replace full sonographers. And working on call with ER docs that know how to do Pocus, it really actually reduced our call because they were very proficient at finding those emergent findings. And I do think it comes back a lot to patient care and what would I want? Do I want them to call the sonographer and they have a half an hour to get there, or do I want them just to pull out their thing, take a look real quick, and they're on their way? So I think it just expedites care in the right ways.
Yes.
I also do think it is very user dependent, and so having the correct training and the wherewithal to understand your limitations with it is very important for any healthcare provider.
Yeah.
Like, I'm not the best person for this. Maybe I should get a person who's been fully trained in it, or ask a colleague kind of deal. And so I think that may be a little bit of the limitation, but I think if there isn't anybody better prepared to do that in an introspection than a doctor who's wanting to take care of people. In the in the low resources areas where you guys are, like, with ultrasound just being safe and portable, and like, why not get it out there, get it in the hands of people that are just doing what they can with what they have, and see where ultrasound can go. Like, it's just a very underutilized imaging modality as it is, and we're just finding more and more ways to use it as we improve the technology and bring it around the world. So I agree. I think it's neat how you guys are using it for everywhere you can, and in unique ways that we just don't typically see it used.
Right. Well, yeah, right, and while still respecting, the capabilities of it. We're not just, when you talk about increase in access, for the right reasons. We always want to keep the ethical considerations. Yeah. And we're not using it for entertainment and to see a baby every day, but increase in access especially when you don't have other modalities and other imaging. Absolutely, we're big fans. Speaking for you, but we're big fans of increase the access when ethically done.
One of the things that got me right into point of care ultrasound was seeing how portable handheld ultrasounds can be, and not having these huge machines where you can just pull this out, put your phone, a tablet, and start scanning people. And I guess that's a good thing, especially for low resource settings and rural areas. Like, having one of these devices could help a lot.
Yes.
And the last question I have is, what do you think, in your experience, might be like the best utilities of point of care ultrasound? Like, let's say in an ER department, and because you mentioned that it's great that having emergency physicians know about point of care. So I don't know, what has been your experience towards that? Where do you think it can be most applicable to?
Yes, I think in the trauma situations with just knowing where an entry point might be, or a bleeding, is this patient filling up with fluid or blood or something or not, and being able to kind of tell where. A lot of that in the lung as well. I think that's a huge application, and even for areas with maybe first responders with traveling. If you're in some sort of ambulance, and if you're close by a facility, great. Maybe you don't need the point of care ultrasound, but to be able to track changes, we do this on flight medics, helicopters, long ambulance rides, being able to just to track the patient's stasis or stability. I think that's exciting. And then I think it's exciting when we can, an example is in the eye. There's just this great way where normally we would have to, or they would have to order expensive labs, wait a long time. And so there are a few applications where an ultrasound, fairly immediately can give you that, knowledge where you feel secure to move forward. So I think those applications are really exciting because they just pass a lot of hurdles.
Perfect, thank you.
Yeah, I would agree. Emergency rooms and rural care and that kind of stuff is probably the ones that are going to benefit from it the most. I can see, like, even going into like family medicine and some of that stuff too, if you've got patients that just aren't going to come back, and you need to, make a diagnosis sooner than later for them, be it gallstones, saying like, look, you have to stay, we got to get you into surgery or something, or cholecystitis or something. So I think there's some room in it for making sure that people get continued care and are not leaving with undiagnosed, or and with the bedside piece of it, like, you can choose then as a doctor, like, are you billing for it, or how are you going to incorporate it into your care? Maybe it's just part of your exam for everybody. And so I think there's some flexibility in the cost of it too. It's the formal ultrasounds can be expensive depending on where you go, and if it can be done bedside, it saves time and money a lot of times too. So
and it's pretty curious how it's getting incorporated into medical schools, into more residencies every single day. So I think it's going to be really interesting where this gets in some time.
Yeah, there's a few schools that I've heard of now that like instead of stethoscopes they get butterflies.
Wow.
Butterfly machines. So, yes, it's in many standard in many curriculums now, and it's really exciting to see you and other providers excited about it and really latch on, because even whilst it's in a curriculum, maybe it's an option and maybe we breeze by it, but it's exciting to see people utilize it.
So yeah, thank you to Molly and Kate for being here with us for a week, and I'm gonna leave all the socials and links and everything where you can learn more on Point of Care and maybe even follow them on their socials. So thanks to them.
Yes, thank you.